Before we go too much into, before we start into the modes, we're going to first take a little review on setting a mode for the Draeger Evita XL. How you would do it. Take a look at the machine. This is the ventilator. As you can see, the ventilator is in standby. It says standby, patient, not ventilator. Therefore, if you were using the actual ventilator, you'd see this. You would know not to place the ventilator on the patient because he's not being ventilated. So, just before we go into actual modes and stuff, we're going to talk about how we would set a mode. Normally, you would, to set a mode, this is a touch screen. So this ventilator, you would, since this ventilator works on touch screen, you would just, I'm going to use my mouse, but pretend that this is my finger to the actual ventilator. Let's say I wanted to go into SIMV. I would touch this with my finger, and down here there's a little rotary knob. I would confirm if I want to enter the mode by hitting this rotary knob. Now, notice that SIMV is highlighted. If I want to go back to IPTV, I can do that. Now, this is a simulator, so it's going to work a bit differently here because I have a rope on the middle of my mouse, the thing that, you know, the mouse, switches to. I have a rotary knob. Draeger, the company, has programmed it so I can actually, instead of going over here to click the rotary knob, I could use the little wheel on my mouse. I could press that in because here the wheel, notice, to change the value, you would turn the rotary knob. See, I've selected FiO2. Oops, hold on a minute. Notice, change rotating the rotary knob. Look at the number. Since my mouse has a rotary knob in the middle, it's programmed to where I can actually use the rotary knob. Notice I'm changing this. I'm not going to the rotary knob over here. I'm using my wheel. Then I click on the wheel to confirm. So now, these are not actually, I'm not actually ventilating my patient right now as he stands by. But let's go ahead and review our patient. These are my, since this is a simulator, I can control the patient lung dynamics. The patient is breathing at a rate of 25, yet I have the sensitivity set to 0, the strength. Therefore, he is actually not breathing. His lung compliance is 30. His resistance is 11. His tidal volume is 700. But since he's not breathing, he's not going to create that tidal volume. And notice he has an endotracheal tube, a 7.5 ET tube. Excuse me, 7.0. I'm going to change that to 7.5 because I have automatic tube compensation, and that's what it's set. So, let's start ventilating the patient. To do that, we would hit this button, and we would touch it with our fingers, but we're going to use the mouse. Confirm it with the rotary knob. Now we are ventilating the patient in IPTV. I have his, we'll go ahead and review the settings. FiO2 at 100%. Tidal volume at 1 liter. Inspiratory time 1.50 seconds. No, 50 seconds, 1.50. Rate 18. Flow of 120. Peak of 4. And I can come over here and we have a sensitivity of 0.6. I'm going to put that on 1.0. Alright, thank you. As we were saying, trigger is set to 1 now. The Evita XL is an IPPV. This patient, there is no spontaneous effort. So we are delivering a rate of 18. He is getting a mandatory rate of 18. The only reason we have a spontaneous rate of 0.1 is because the ventilator is just trying to equivalent. This is the pressure waveform. There's a volume waveform. If I turn this off, we'll put the low waveform down here. Mom's. Yeah, for sure. Yeah, it's not. I do tend to use one day because it's not like but to make, now that you see that I have X's out of the settings menu, to go back to the settings menu where I could set stuff, because now I can review it but I cannot set it. I can review the FiO2 and the rate and the frequency and etc. But I cannot set it. If I hit this button, I will be able to set it. So let's start. IPPV. Independent tank positive pressure ventilation. It's volume control. The patient, it would be good. It could be used. It is usually used for support, full support of the ventilator patient. A non-breathing, paralyzed, and sedated, comatose, brain-dead patient could be on this and kept alive. So let's talk about it. We're delivering a rate of 18 at a tidal volume of 1,000 milliliters or 1 liter. At an inspiratory time, which is how long it takes to get that 1 liter in, of 0.5. I mean 1.50. 1.5 seconds to get the breath in. Notice. I could decrease the inspiratory time and you would see this waveform that wouldn't linger so long. Go ahead and do that. And watch this waveform. It's a lot shorter. Now if I increase the inspiratory time, let's go to 3 seconds. This waveform is going to be, this plateau is going to be a lot longer. See, but I don't want to fool around with that too much. I want to keep him on 1.5. So here we are. So it is giving him a tidal volume every around 3.5 to 3 seconds. Let's say my patient wakes up. Maybe he starts, I'm going to turn this tidal volume down to 300. Say he starts breathing 20 times a minute. Now notice, when he triggers the ventilator, this little light's going to blink. when he tries to take a breath. So I'm going to start giving him breaths. Or not giving him breaths. He's going to start giving the machine breaths. Notice he's breathing now. Notice this rod is blinking. He is triggering. Now notice. He's breathing at a tidal volume of 300. VT, that's tidal volume. Notice, the inspiratory VT, why isn't it 300? Since he's breathing 300. Well, the ventilator is supposed to be giving him 1,000 every machine given breath. But due to the compliance issue we have with him, a lot of the volume is going to get lost in the tubing and in the circuit. So let's still just answer my question. Why on earth would the ventilator give you 972 if he's breathing at 300? That's the thing. IPPV, which is also known as assist control in some ventilators. The patient can take an effort. He can take a breath. But the ventilator is going to give him what's called an assist breath, which means he can take that breath, but he's still going to get it at the set tidal volume, which is 1 liter, and at the set inspiratory time, which is 1.5 seconds. So he's breathing, but the machine's still doing a lot of the work. Therefore, this is not if we want to wean our patient off the ventilator, this will not be a very good mode. Maybe at the beginning of weaning, but definitely not during the whole weaning process. So he breathes 300, yeah, he's still going to get 942. Because, like I say, 1 liter, a little bit of it's going to be lost in the tubing. 1 liter, see? You just got that. So, as you can see, the mandatory breath rate is 18. But he's breathing at around 20 to 22. So you see he is breathing, this guy breathes. So look at the pressure waveform. Spontaneous breath. Spontaneous breath. In IPPV, they don't call them an IPPV assist control, which is the same thing as IPPV. They don't call them spontaneous breath because they're not spontaneous. He triggers the ventilator to give him what we call an assist breath. Which means the ventilator will assist him, but it's going to give him the ventilator tidal volume. So it's basically the ventilator is saying this. The ventilator is saying this. Alright, you're an IPPV. I'm going to give you a specific rate, which is 18. Tidal volume of 1 liter. I time, the inspiratory time of 1.5 seconds. If you want another breath, fine, go ahead and initiate it. But you're still going to get what I deliver, which is 1 liter at the set inspiratory time, 1.5 seconds. It doesn't matter if you want another breath. You get the breath, but you get the amount that I give you in the time I give you. So this might be used if a patient is completely ventilator dependent, or if he is starting the weaning process, yet not ready to go to other modes such as SINV or Cpap or Bipap. SINV, that's going to SINV. SINV, synchronized intermittent mandatory ventilation. Our patient is still getting the rate of 18. Next low, SI and V. Synchronized intermittent mandatory ventilation. Patient's still getting a rate of 18. 22. So he's triggering the ventilator. He's still triggering the ventilator at 20. Notice. See that 268? In the previous mode we discussed IPTV and how if the patient wanted a breath, he could get the breath, but he got it at the set tidal volume and at the set eye time for inspiratory time. Guess what? That doesn't apply here. This patient is an SIND. If he wants a breath, let's say he's breathing at 300. If he wants a breath, he gets the breath. And he controls not only the breath, but how much is delivered. For example, just so you can see it better, I'm going to turn the mandatory breath down to 10. So we're in SINV. Patient is taking spontaneous breath. 21. He is on a pressure support of 10 and a peak of 5. Pressure support. It's basically when the patient breathes in, the machine gives pressure to ease his work of breathing. The lower the pressure, the more work of breathing he does. You'll notice it says ASB right here, short for assisted spontaneous breathing. If we were to turn this off, he will not. The ASB would be on. He could still breathe, but it would be very hard. He'd be breathing through a tube without any flow. I'm going to put him on 15. Continuation. So as you can see, he's breathing at 20 pounds per minute. I've got the ventilator rate set to 10. 9.7 is the mandatory rate that he's getting. As you see down here, it says 9.7. So he is getting a mandatory rate, yet in between, you can take the spontaneous breaths if you want. These little breaths down here, these are spontaneous. Where you see this line. So, this would be what I call a partial spontaneous breathing trial. The beginning of breathing. A patient can be maintained on full support with this mode. However, it can also be maintained on partial support. And you're probably wondering, I'm talking all this about pressure support. What is pressure support? Pressure support. Let me explain this better. Okay. If I turn this off, and he still breathes, turn the pressure support off. He can still breathe. Let's go ahead and turn his breath rate up so you'll be able to see it more. Oops, not down, I said up. So now, he's breathing at 33 times per minute. We'll let the ventilator equivalent fibrillate. As you can see, his spontaneous breathing frequency is going to go up. Sure. Hold on. Right. So as you see, the spontaneous frequency has gone up. Now there's no pressure support, so he's breathing at, let's say he starts breathing at around a target volume of 100 to 200, which is not good. It's too low. So he's breathing real low. These are the mandatory strokes at around 10 per minute, and these are the little breaths he's taking. Now, there's no pressure going to this circuit. So if you want to know what he probably feels like, put a straw in your mouth, clamp down on the straw and breathe, and then attach that to a water hose while the water's not running, but while it's plugged into the water outlet on the wall. I think, obviously, it's going to be very hard to breathe. He has a tube down his throat. He's got the hose to the ventilator connected to the tube, and he's got this tube connected to the ventilator. So imagine breathing through a machine without any pressure. CO2 is going to build up, and it's going to be very hard to breathe. So a lot of the patients that are on SIMD that are not on any pressure support, it's just like breathing through a straw, except 3 or 4 times worse, because you got the big hoses and stuff to breathe through without any air flowing. If I turn, notice the pressure waveform, he's really struggling here. I mean, like I said, these are the machine-given breaths, and these are his breaths. Let's turn the pressure support up to, because if you see the tidal volume, it's like 203. Turn pressure support up to 14. Let's see what he does. Notice, he's breathing just fine now. His tidal volume is 973. Now, his tidal volume being so high, why is it so high if he's only breathing 200? Is this like assist control or IPTV? No, it is simply pressure support. Pressure support augments the patient's effort to make it easier for him to breathe. It gives him pressure to assist his breathing. So when he breathes in, he gets pressure. When the flow drops, when the flow of his inspiratory stage drops to a certain percentage, the ventilator lets him go into exhalation. And in between his spontaneous breaths, he gets the mandatory breaths, which are the high rate. That's the mandatory breath. Spontaneous breath, 388, and that's because it's not 200 because of the pressure support. If I turn his pressure support up to like 31, let's see how high he gets. So notice, even the spontaneous breaths are supported with high pressure. So that means he is getting around a liter, 800, 900, 1,000 milliliters per breath when he tries to breathe in. Now in SIMD, we're talking about pressure support and such. I think we covered that. Now, in SIMB, he's breathing, so he's getting pressure support. But, since he's got an IPPV, what happens if he stops breathing? So, my patient isn't breathing anymore. As you see, spontaneous breath rate's going to go down. There is no spontaneous effort right now. So, if this is a partial wean mode, then that must mean my patient's going to die now, since he is not breathing. Remember how when I was talking about spontaneous breaths, I also mentioned there are mandatory breaths in between, where the mandatory breaths are still there at the set rate, set time of volume, and set inspiratory time, just like IPPV. However, there are no he could breathe if he wanted to. He could breathe in between the mandatory breaths, but he's not breathing. But that doesn't mean that he doesn't get mandatory breaths. He's still getting mandatory breaths. So the ventilator is still supporting him. So SIMB is a set rate, a set time, a set volume, with the ability to have pressure supported breaths in between. ASB, as you see right here, is short for assisted spontaneous breathing. If we turn pressure support off, it is now, ASB is gone. You can still breathe, but it's going to be dead space, and it's going to feel like breathing through a straw. 34. So therefore we have pressure support at 34. So after this is what we would see if a patient was completely asleep, not breathing, and the machine was doing all the work. And this is what you would see if the patient was breathing on his own with the mandatory breath. So if he's breathing, his ventilatory rate, his spontaneous rate will go up. And as you see, we'll let that go up some. Now he is breathing spontaneously. So spontaneous effort. Let's go ahead and put him on 25 or 20, and you'll watch that go down. So now he's breathing some, but the ventilator's still giving him the breath. And that is SIMB. We'll let you watch the waveform. Okay. So, our patient is breathing spontaneously, as you can see. He is breathing well, and let's see. He's breathing at 200, but with the pressure support of 34, he's breathing at 950. 34 is an extremely high pressure. Let's go down to 12 to see how well he does. As you can see, he's still getting mandatory strokes at a rate of 9.8, around 10, so. He's doing real good. He's maintaining good tide of volumes. Maybe the tide of volume is a little bit, tiny bit low. We'll go ahead and go to a pressure support of 19. There we go. Now, some of the techniques we would use to wean an SIMD would be to decrease the mandatory rate. So instead of 10 breaths a minute, we could turn it down to like 5 and see if the patient is still able to compensate with a low breath rate. So now, every 12 seconds, the patient will be doing a mandatory breath. These are his breaths. His breaths. Mandatory breath, mandatory breath. So as you can see, the patient is still breathing very adequately. He is maintaining his breath rate at 22 to 24 with the ventilator giving him around 4.9 to 5 breaths per minute. So what's our next step? Well, we could, if the patient starts decreasing his ventilation, his volumes, as you'll see on the volume waveform, we could decrease the pressure support. Let's go to a pressure support of 14. Now, before we go on, I want to talk about something important. It's called the trigger. This is how much this patient has to pull to get a breath. Or to get, if he's in IPPV, he'll get an assist breath. If he's in SIMD, Cpap, he'll get a spontaneous pressure supported breath. An AFB breath is that called. The lower the number, a lot of people might think that the higher the number, the easier it is to get a breath. No, the lower the number, the higher, or the easier it is to breath. So he is on very low sensitivity now. 1 is low, but 0.3 is extremely low. As the patient gets better, we would decrease increase the number to decrease the sensitivity of the ventilator. Just go to 2. See how well he does. He was doing 500. He's doing great. He just hit 1 liter, but I think that was that was a mandatory breath. But now that he's doing well, the doctor comes in and he's like, hey listen, I don't think he needs those mandatory breaths again. anymore. Let's go to Cpap. There are two ways to go to Cpap. You could change the mode just like you would. You could go to IPPV, or no, just like you would if you were going to IPPV. Touch it and then hit the rotary knob. To go to Cpap, you could touch it and hit the rotary knob. But there's also another way. Quicker way is to just notice it says SIMB. If I decrease that rate to, if I decrease the F or frequency to 0, look at where it says SIMB up here. Cpap. Cpap is short for continuous positive airway pressure. You and or somebody else may have sleep apnea. And have sleep apnea is basically where you stop breathing in your sleep. Treatment for that is where you put this headgear on and a mask on your nose or your mouth, or both nose and or nose and mouth. And then you, the machine gives you continuous positive airway pressure. Cpap is short for continuous positive airway pressure. This is also used, it's more in the ICU on people on ventilators. What Cpap is where the patient gets a continuous pressure. I'm going to turn pressure support off for a minute. But the machine gives continuous positive airway pressure. And it helps keep the lungs and the airways open when you breathe out. PEEP is another name for Cpap. In a mandatory mode where the ventilator gives breath, does give breath, such as an SIMV or IPPV, PEEP is considered PEEP. PEEP and PEEP alone. Positive and expiratory pressure. If somebody puts their hand over your mouth and tells you to blow out, it's definitely not going to be as easy as blowing out with an uncovered mouth. That's what PEEP is. The higher the pressure, the harder it is to blow out. This is what they use in premature babies sometimes, and then sleep apnea. Keeps the airways open. That way, obstructive patients with OSA or obstructive sleep apnea find it easier to breathe. It keeps their airways open, so that they can either reduce or prevent apnea altogether. Now, Cpap sometimes isn't enough, so we can add pressure support to it. Pressure support must be above PEEP. Let's go ahead and put pressure support of 11. Notice the mandatory breaths are 0.2, which is 0. It's going to hit 0 in a little while. But the mandatory frequency right here is going to hit 0. The spontaneous frequency is 20. So the patient's doing all the work on its own. He's doing all the work on his own, as you can see. So that means this ventilation mode will not be able to support completely apneic patients. So if he couldn't breathe, he would not be able to use Cpap. If you notice, see, he stopped breathing in SIMB and he still got a rate. If he stops breathing now, I just look at the waveform. Apnea. No breath rate. It's going to go down. We can configure an apnea ventilation back up, but we haven't done that. You'll see down here it says apnea ventilation off. So let's say he starts breathing again. He's breathing again. And Cpap. So Cpap basically is a spontaneous breathing mode. It can be used for a complete spontaneous breathing trial. Patient breathes on his own, his or her own, while he gets pressure support and Cpap. Or pressure support can be turned off by dialing the pressure support to zero, but we're not going to do that. Now while we're at it, let's go ahead and talk about, let me see how much time we have. Let's go ahead and talk about some of these other settings. We'll talk about FiO2 for now. The O2 is the amount of oxygen. This patient, throughout this video, has been getting 100% oxygen. We can turn this down, and that's basically how much oxygen will be given through the ventilator when he takes a breath, or when the when the machine gives him a breath. Because the ventilator is hooked up to oxygen. We can go all the way down to 21, which is room air, and all the way up to 100. I'm going to put him on 94. So he's getting 94%, which is about room air. I mean, about pure oxygen. That's a little bit of room air. So while he's doing that, while he's breathing, he's also getting oxygen. Now while he's in Cpap, these three modes, these three settings, the tidal volume, high time, and breath rate don't mean a thing. It's only when I turn the breath rate up or the breath rate on will these buttons mean anything. Same thing with the flow. Flow doesn't mean a thing while he's not getting breath, because he's taking breath. So he's doing well. We're going to go ahead and go to our next mode. We'll go ahead and put him on a ring 8 for the next mode. Bipap. Bi-level positive airway pressure. BIPAP. Sort of like Cpap. Only it can be used for spontaneously breathing patients or non-spontaneously breathing patients. This patient is breathing spontaneously. Bipap is used for patients with disorders such as COPD, neuromuscular diseases such as Lou Gehrig's disease. Can be used with patients with SMA, biomuscular atrophy. As you can see, we have our PINFP, that's inspiratory pressure. ICAP, let's go ahead and press that real quick and turn this off. Bipap consists of two pressures. IPAP, IPAP, and EPAP, EPAP. IPAP is inspiratory positive airway pressure. EPAP is expiratory positive airway pressure. For this, I'm going to turn off pressure support. As you can see, as I was saying, Bipap, our patient is on Bipap. He is breathing 31 times per minute. Let's turn the rate down to 3. Notice she's breathing. We will turn the inspiratory time up. Now watch the pressure weight on the inspiratory pressure up. Watch his breathing. What you just saw was a mandatory breath. Basically, Bipap is pressure controlled ventilation. If you notice, let's say he stops breathing. And notice the spontaneous breaths are still not there, even though I turn the inspiratory pressure up. He is not getting the IPAP. For spontaneous breathing, the IPAP would be the pressure support. So I'm going to put this on 15. Okay. Notice, now when he breathes, he gets the pressure support. Now if he stops breathing, of course he's only going to be getting 3 breaths per minute. Let's go ahead and put that on 15. Notice there is no tidal volume. Instead of tidal volume, we regulate we increase the pressure to get a tidal volume that we want. Since he's not breathing, he's not going to get pressure support since he's not breathing. So, you notice that he's not breathing, I have the inspiratory pressure set to 30. It depends on his non-compliance resistance, but the higher the pressure, the higher the tidal volume he will get. For example, I'm going to put him on 10 of tidal volume. This is IPAP. When the machine gives him a breath, it's the inspiratory pressure instead of the tidal volume. As you can see, he is only getting inspiratory tidal volume, which, like I've said many times, is displayed over here, right here, 178 or 176. Normally, if I were to increase that, I would increase the tidal volume, but there is no tidal volume. Let's try to increase the inspiratory pressure for IPAP. The tidal volume immediately starts going up. The EPAP or PEEP. EPAP is set by the PEEP, because EPAP is the expiratory pressure. So let's set the EPAP or PEEP to 15. So now he is getting the rate with the pressure IPAP of 20, or PINSP, inspiratory pressure of 20, expiratory pressure, also known as PEEP, which is also in Bipap is called EPAP, is 15. Let's go back to 5. We could jack this pressure all the way up to 39. Mark the inspiratory tidal volume. So that is Bipap. If the patient wants a spontaneous effort, he can get the IPAP through the pressure support. That will be the inspiratory pressure. When he breathes, spontaneous effort. Mandatory effort to control. If you want to control the tidal volume with mandatory effort, you're going to have to use the pressure. Notice he's getting around 900 to a liter of ventilatory breath. So therefore, let's go back to 25. Our next mode we're going to be discussing is APRV. APRV. Okay. This is sort of a, in a way it's very easy, in a way it's very complicated. For patients who are not being ventilated sufficiently, with the other modes of ventilation, such as SIND, IPPV, we can use a mode called APRV. Airway pressure release ventilation. Now notice, we have different settings. We have T high, which is let's go ahead and set that to 3. This is the inspiratory time, which is 3 seconds. And we have T low. That's set to 0.37 seconds. That's the expiratory time. Let's go ahead and increase that to 2 seconds. We're not going to worry about the ramp. Talk about that later. We have P high, which is 15. Let's go ahead and put that on 26. Let's go ahead and put the P high is the inspiratory pressure. The P low is the expiratory pressure. Sort of like P and Epap. So let's go ahead and put the E on the expiratory pressure on 6 or 9. So basically APRV, what it's going to do is it's going to give longer inspiratory time and shorter expiratory time. We can do an inspiratory time all the way up to 30 seconds. But we're not going to do that. We're getting a rate of 12 right now, mandatory rate. If I need to increase the rate, what do I do? Normally I would just hit the F button and turn up the frequency. For here, let's say I want to decrease the rate. So I'm going to decrease the expiratory time to 0.10. In the inspiratory time to 1 second. For patients with acute respiratory distress syndrome, really requiring a lot of ventilatory support, this would be a great mode. And the best part is, the patient can breathe spontaneously with it. So let's go ahead and put this patient on 32 or on 30. And it will not affect the machine. Patient can breathe right along with it. APRV is a favorite mode. Now the mean airway pressure, that can be increased to improve oxygenation. So this PMEAN, P-mean, that's the mean airway pressure. That's the main pressure, not the inspiratory pressure. It's not the peak airway pressure. The peak inspiratory pressure. It's the mean pressure, the main pressure. If I want to increase that mean, I would come up here and increase the inspiratory pressure and increase the inspiratory pressure. Notice the means when we go up the slide now. Not really slide. 35 would be used for people who really have oxygenation trouble. In a patient on this high, on FiO2 this high, would need high mean airway pressure if they're still not oxygenating. And let's say I'm still not happy with the rate because we're still only getting let's say if the patient stops breathing, let's see how many we're getting. Patient has stopped breathing. We're getting around 20 or so breaths per minute. Let's say I need to increase the rate. I could decrease the inspiratory pressure because I've decreased the expiratory pressure a lot. So let's try this. Now I'm going to get a rate of around 50. I could, if I decrease the inspiratory pressure, inspiratory time enough, I could, in fact, do high frequency. The mandatory rate is 60, 70. I'm going to decrease the expiratory pressure. Now watch. See these two breaths right here, this one and this one? He is now going to get I'm going to decrease the inspiratory time just to, there we go. These two breaths right here, the patient's going to get real high breath rate here. So watch. This mandatory rate's going to go up a lot. And in order to increase the inspiratory pressure, I'm going to have to increase the alignment. I'm going to go ahead and increase the airway pressure alarm to 52. You never want to do this. You have to see absolutely dire need of doing it. We're now going to the 300, so let's go ahead and increase the pressure. Oops, not the inspiratory time. The inspiratory pressure. Now the mean airway pressure is going to go up real high. This is actually unsafe to a patient. I could go up higher. I'm going to pause this. The mean airway pressure is now 57. You never want to do this unless your patient is like in dire need of it, like severe ARDS. Because if he's this bad, you want to consider the oscillator, the high frequency ventilator. But actually we are now delivering high frequency ventilation. Nothing like the high frequency oscillator, but it will do. So we'll go ahead and let you watch this. Tidal bombs are only 46 milliliters, but we're doing a high breath rate, so that's okay. But honestly, if they're requiring that high breath rate, we're going to want to go to the oscillator most likely. But this is possible. Hey, well that. So far we have discussed IPPV, SIND, Cpap, Bipap, and APRV. And we have discussed pressure support. Our next mode of ventilation and our final mode of ventilation we're going to discuss MMV. Let's go ahead and put our patient on a rate of 10 and on a tidal volume of 600. Get a good started. The best part about this ventilator is the evita XL. You can press the question button and you can read about the mode. MMV ASD. Okay, first of all, I'd like to discuss what minute volume is. If you notice on my videos, this ventilator shows something called EMV. That is minute volume. This is, now unlike milliliters, as tidal volume is related to minute volume, MV is in liters, and it's the amount of milliliters placed in the lungs every minute. Now, not every breath, as this is over here, but every minute. Now, this patient's lung compliance is sort of low, so therefore, it's going to be a little bit off. But if you want to calculate the minute volume, you will multiply the rate times the volume. So 10 times 600 will be 6,000. That would be 6 liters. Give you the for non-compliant, he's only getting 5.86. Let's talk about MV. If the patient starts breathing, let's say our patient is not breathing. So he's not breathing right now. The ventilator is taking over. However, let's say he starts breathing at a rate of 20 times the 400. Let's see, I'm going to do a rate of what should we do? Rate of 20. 400. So 400 times 20 would be 8,000. That would be 8,000 liters. Not 8,000 milliliters. So he is now breathing. Start our patient breathing and we're using pressure support of 15. So it's going to be a little bit more than 400. But notice, as he breathes, the mandatory rate goes down. In this mode, in MV, if the patient breathes spontaneously, the ventilator is going to ignore him. It's not going to give him any mandatory rate. The only time he gets a mandatory rate is if his breath rate goes down, or his minute volume goes below 6,000 milliliters or 6 liters per minute. As you see, he's breathing. Mandatory rate's going down. Spontaneous breathing's going up. Frequency's going up. So this mode might be used for patients who are recovering from surgery and who are breathing on their own some, or for those we are trying to wean off the ventilator. But if you notice, if the patient's breathing, the machine's going to say, hey listen, okay, you're breathing, I'm happy with that, I'll go ahead and let you breathe. But let's say the patient decides, the patient starts to go unconscious. His breath rate slowly goes down. Go ahead and go up to 600 for the patient spontaneous effort. So it's going down. Now watch the mandatory frequency. If it goes all the way down to 3, notice. The minute volume is going to start going down. And it's really going down. So what happens to the mandatory frequency? So there's no more spontaneous effort. Watch the mandatory frequency. Watch the minute volume. Mandatory frequency is going up. So, if the patient decides, if he wakes up and starts breathing on his own, he'll get breaths. He can breathe on his own with pressure support, if desired. Hence the ASB symbol. But if he's not able to breathe, and he starts drifting into in and out of consciousness or drifting into sedation, he'll start getting the mandatory rate, or enough to keep this minute volume above 10, which is not doing a very good job because of this compliance. But it's going to get there. And this will be good if he stops breathing altogether. Notice the minute volume is going up. So the patient breathes, the machine is going to say, okay, you're breathing. You're breathing above my rate, and your minute volumes are good. Go ahead and breathe all you want. You still get pressure support, but I'm going to let you breathe. Patient gets tired. And stops breathing or slows down, the ventilator is giving up. Your minute volumes are low, and they're starting to drop down. You need a little bit of assistance. So here's some breath from me. So that is minute volume. MMV. Minute volume ventilation. And those are the modes of ventilation. The most common modes. We have PPS, personal pressure support, but we're not going to go into that today. I'm going to leave you with some waveforms and allow you to watch As I forward the mode, and we'll go ahead and review IPPV, intermittent positive pressure ventilation. Patient is on full support. He doesn't breathe. He gets the set rate at a set tidal volume, at a set inspiratory time. If he wants a breath, he can take that breath. But an IPPV, even though he takes a breath, it's called an assist breath. Because he's only going to get he can get the breath, but he's only going to get it at the set tidal volume and at the set inspiratory time. SIMV, synchronized intermittent mandatory ventilation. Patient gets the set rate, the set tidal volume, and at the set inspiratory time. However, if he wants a breath in between those mandatory breaths or supports, he can get it with pressure support. And that's a backup rate. So if he decides to quit breathing, the backup rate will continue. This could be used for weaning. And with the pressure support, as you start weaning the breath rate down, that will be considered a partial breathing trial, or PSBT, partial spontaneous breathing trial. A complete spontaneous breathing trial would be to turn off the rate and put him in Cpap, turn on Cpap. Or you can select Cpap from the mode, which is over here. But if he's an SIMB, or if we think that he's going to be able to go to Cpap and stay on Cpap, I would just, hit this and I'd confirm it. But if I just thought he'd just be there for maybe about 10 minutes, I would just, turn off the rate. No, you can't do it. So, Bipap, bi-level positive airway pressure. 2 levels of pressure, IPAP and EPAP. Patient can breathe. Inspiratory pressure is IPAP. Expiratory pressure is EPAP, also known as PEEP. Cpap, continuous positive airway pressure. Cpap is basically what keeps the airways open while the patient's breathing. If additional support is needed, pressure support can be administered. Pressure support must be above PEEP. Now, this could be a complete and it could be like Bipap, only Bipap still has a backup rate. Cpap, if you integrate the pressure support, if you turn it on above 5 above PEEP, that would be the inspiratory pressure. So that could be considered Cpap or Bipap within Cpap, only a spontaneous Bipap only. APRV, airway pressure release ventilation. It's used, it's a special mode, and what it does is it basically keeps the airways open to keeps them from de-recruiting, which means keeps them the alveoli and the lungs from closing up. It's used commonly for patients with hard acute respiratory distress syndrome. As demonstrated earlier, it can be used for high frequency ventilation. But if the patient really needs high frequency ventilation, we're best using the HFOV, high frequency oscillatory ventilation. Minute volume ventilation, the MMV, minute ventilation. Basically, the patient can breathe spontaneously if he's above the calculated minute volume. If he goes below the minute volume, for example, if we set a rate of 10 and a tidal volume of 600, 10 times 600 would be 6 liters. So, the patient, the ventilator would calculate the set limit as 6 liters. Patient breathes above the 6 liters. He can breathe all he wants with pressure. He starts slacking and starts maybe going off to sleep and going into sedation. The ventilator's going to take over and say, hey listen, your minute volumes are sort of low. I'm going to... Notice we have our patient on IPPV. For the next following, for the next several minutes, you're going to get to watch these waveforms and watch how the patient's interaction will affect the waveform, the ventilator, and the parameters displayed on the ventilator. I hope you enjoy. We have our patient and IPTV, and if you didn't skip through the video, you know what IPTV is. You should. Right now, the patient is doing what we call riding the ventilator. The ventilator is getting him breaths at around 9.8 or 10, around 10, because I set it at 10, but it's normal for it to be off a tiny bit, because this is a simulator. He is on 100% oxygen. Go ahead and put him on 90% oxygen. You see the settings down here? And he's riding the ventilator. He is not taking any effort. Patients, let's say our patient just had surgery, or he was in a coma and for some reason he starts waking up. Well, the first thing on his mind is going to be like, what is going on? He's going to wake up, he's going to be like, what's this tube down my throat? And what's in the back of my throat? Because it's going to slowly come to him that something's not right. So the first thing he'll probably think is, what's going on? I can't seem to swallow. It feels weird. There's something in the back of my throat. It feels like. And then he'll start to cough because the ventilator will give him a breath and he's not used to that. So, and then once he realizes something's not right, he'll start to panic. So he'll start. Let's watch. And he's literally going to start. Bipap. So the nerves, the alarms were set so close together to alert the nerves of any sudden changes. And all of a sudden, you look at the waveform and you know something is not right. You look at your patient. Well, first of all, when you hear a ventilator alarm, first thing you do, don't even look at the machine until you look at your patient. Look at the patient. As you can see, this patient is literally fighting the ventilator. I'm going to decrease the airway pressure here, because I was doing something in APRV. We want it in 30. So now he's literally getting panicked. As you see, he's fighting the ventilator. And right now, his airway pressure is 39, but that's because it's limited. So the nurse is going to be like, oh, he's waking up. So him and the ventilator are anything but in synchronous. He is fighting the ventilator. The ventilator's in IPTV, and he is panicking. So first of all, the nurse is going to be like, sir, you have a tube in your throat. You were in an accident and you had surgery. Everything is just fine. Slow your breathing down. And hopefully, slow his breathing down. So maybe she gets tactile reassurance. And she's like, slow your breathing down. This machine, this is the ventilator. Everything's going to be just fine. Finally, he slows his breathing down. It may still be a bit high, because, I mean, that's, if you're not used to it being on a ventilator, waking up on a ventilator, I'm sure it can be very scary. I'm used to it, so, but I'm sure it can be very scary. So, he's sort of calmed down. Minute volume's still high, but maybe we could give him some sedation. And let's say he goes back to sleep. His minute volume is like shrieks high. So we're going to let him, he's going back to sleep, and as you can see, there's no more fighting. The rate will decrease, and the patient will go back to sleep. At this point, due to the patient being so restless, he's probably sick as oxygen saturation is really low, so we're going to put him on 100% oxygen. And now that the minute volume alarm is clear, it's still here because it wants to let us know. And that's in case you didn't know, your patient had a very high minute volume. You just hit alarm reset and it's rolling off. By the way, it's a wheel on my mouth that controls this knob. As I said. Patient is calm now. At this point, the nurse may actually decide to put him in SIUD, and we'll put pressure support on. He has to see how much he can do on his own if he wakes up. So a little bit late, he's riding the ventilator. It's what we call, that's the terminology for basically letting the ventilator do the work. So he's riding the ventilator. And he's calm and everything's good. And then he starts to wake up again. Now since he's in SIMP, again it's sort of frightening waking up with that tube in his throat. So maybe he'll start breathing at 30. But you can see him in the ventilator still in sync, because since the ventilator is letting him get his own breath, and it's not fighting to get him the breath that it wants him, everything's good. He's getting his own breath. The minute volume high is just letting the nurse to say, hey nurse, listen, your patient is triggering the pressure support on the ventilator. Better check it out. Maybe he doesn't. Maybe you should decrease his ventilator rate. Maybe he can go into Cpap, or maybe he can deactivate it altogether. So she sees the minute volume is high. And seeing that, she's like, he seems to be doing well with the pressure support. He's triggering the ventilator. I think he might be able to be extubated. Or at least, let's try and see how he does. So let's go ahead and check the minute volume, which is 13.3. Here we go. It's still relatively close together. So she's like, hey sir, listen, you're on a ventilator. I'm the one who you saw earlier when you first woke up. I'm going to decrease your rate to see how well you do on your own. She might spray some stuff in the back of his throat to keep him from gagging. So, let's pretend that this patient's only been on a ventilator for like maybe 4 to 6 hours. We're going to put him on a rate of 4. See how he does. His spontaneous respiratory rate is 30. Mandatory was like 10. So it's going to go down since we put him on 4. And we'll get the minute volume higher on. You should be getting it in a minute, so get minute volume lower now. We should. And now we see the patient is breathing spontaneously, but his rate's a little bit fast, probably because he's still trying to calm himself down. So the nurse may be by this. She may say, "So you're breathing down there. You're on a ventilator. Everything is going to be just fine." And of course she'll have capnography, so she'll see that his capnography is real low. So maybe he'll slow his breathing down 15 or so. Minute volume low on the sound, but that's okay. We'll just, we'll deal with that. We'll watch the minute volume go. As our patient is now breathing, we don't have to worry about the minute volume being so close together. But we still need it close, but nothing like it was. So we're going to let it, don't expect that. So he's calm right now. He is calm. So we'll go ahead and decrease the minute volume some. This is 63, so we'll go ahead and put it on. 5. That would be a little bit too high. There we go. And he is now, partially riding and partially, he is not riding the ventilator. Riding would be if he was paralyzed or if he wasn't breathing. He is communicating with the ventilator. The ventilator is driving and he is communicating. So he's up and about. He's sort of guiding the ventilator. He's guiding it because he is giving pressure support. He's like, "Okay then, I want a breath." And the ventilator's like, "Sure. You can have this breath. Guide me tell me whenever you want a breath and I'll give you the pressure support breath. I'm not going to give you direct tidal volume. I will help you control tidal volume. You will be in charge of actually, if you want another breath, you can take it, but you'll sort of need help." So cool. Patient's breathing just fine. At this point, the nurse decides. hurt. The nurse has decided to place the patient on Cpap. Sir, I'm going to turn the rate off. You will be able to breathe completely on your own. The ventilator will not be giving you any breath on your own. So now he is in Cpap. Let's see how he does. Notice the mandatory breaths are going to go down very quickly. The minute volume will go down, so I will have to change that in a minute. Well, it didn't go down too much, so. Yeah, it is. It's still going down. He's breathing just fine on his own. Finally, the nurse sees that he's doing just fine on his own. I mean, he's breathing just fine. No apnea. Of course, she's going to want to see how he does. He's standing good, so let's go ahead and put him on. 50% oxygen. So she puts him on 50% oxygen. He's maintaining his pressure support, his tidal volume really well. And of course, as he wakes up, that'll improve. 4 volumes may be really high in there. We can silence this alarm. Notice when I silence the alarm, we will get an indicator over here. It's silent for 2 minutes, 13 seconds. 100 seconds. Minute bar is going to come up some. It's going to be alarmed. He's breathing on his own. We still need to keep very close eye on him. The noise I make is to clear my airway. I don't have very good airway clearance, so that's why I do all that. I can't help that. Well, I could, but I could stop doing it, but I get very, very sick. And he seems to be doing very well on his ventilator. At this point, he's doing all the breathing on his own. So at this point, if she doesn't want to directly extubate him, she can use the evita XL oxygen therapy pad for future. what's done is the ventilator is placed on standby. So she's going to be like, sir, you're breathing on your own. I'm going to put you on some supplemental oxygen via the endotracheal tube, via the tube in your throat for about 5 minutes or so to see how you do. This will not give you pressure, just extra flow and oxygen. You will hit this button, and then it will give the option of start standby. You can start. We're going to hit standby. You will touch it since this is a touchscreen ventilator, and you will hit the rotary knob. So you get an alarm saying, "Oh, I'm in standby." She might actually, then we will confirm it by touching the alarm reset, and then hit alarm info. Or no, hit the rotary knob. Then we go to oxygen therapy down here. She could then set how much oxygen she wants to deliver. Do 40% at a rate, at a flow of 40. And this is a simulation, so this is not, honestly, it's not available, so I would just pretend. Let's say we would press this button and it would say oxygen O2 therapy active. And the FiO2 would be delivered. That's delivered to be specified up here. It's monitoring now. Please make serious note. And so the parameters such as volume, EMV, minute volume, apnea, and other alarms like that are disabled because this is just oxygen therapy. They cannot be used with an NIV mask. It can be used with intubated patients or regular face mask. So the only thing that would be monitored is FiO2, and if configured, pulse rate and SpO2 would be measured. But let's say that's not configured. So she'd wean him down off this. Say we go to 30 in the velocity. Turn this up some. If he does okay, she would